Many thanks to Toby Eyre and Graham Collins, together with Lymphoma Action, for the invitation to speak on Burkitt lymphoma at this year's virtual lymphoma management course. My name is Chris Fox. I'm a haematologist in Nottingham University Hospitals in the UK, and I'm going to talk for the next 20 minutes or so regarding very interesting and highly curable but difficult to manage lymphoma known as Burkitt lymphoma. These are my disclosures. So a talk on Burkitt lymphoma, in my view, should always begin or at least involve a discussion regarding the Epstein-Barr virus, which was the first human tumor virus discovered by Sir Anthony Epstein, a British scientist in 1964, through a collaboration with British surgeon Dennis Burkitt, who described these quite remarkable tumours arising in the jaw in African children in the sub-Saharan holoendemic regions of malaria. And within the tumour tissue, Epstein-Barr virus was discovered, and at least for that type of Burkitt lymphoma was etiologically linked to the development of this lymphoma. However, we now know that there are different types of Burkitt lymphoma. The endemic version that I've just referred to around equatorial Africa, mainly in childhood and classically arising in the jaw and facial bones. And then we have the subtype, although rare, that we see most commonly in the Western world, an instance of approximately 2 or 3 cases per million. Tends to be younger adults, sometimes children with a dominant abdominal presentation, but extranodal sites throughout the body. Then, of course, we have HIV-associated Burkitt lymphoma, less common these days, but not abrogated by the introduction of effective antiretroviral therapy. And you'll see there at the bottom there's a variable association with the Epstein-Barr virus, with the endemic version always associated together with malaria co-infection that's thought to cause an immunosuppressive effect to increase the risk. Whereas with sporadic Burkitt lymphoma that we most commonly see in the United Kingdom, usually not associated with EBV, whilst the Burkitt lymphoma associated with HIV, moderately commonly associated with EBV. However, irrespective of the type of Burkitt lymphoma or the EBV status, all Burkitt lymphoma tumours demonstrate a translocation of the c-MYC gene on chromosome 8, most commonly with the immunoglobulin heavy chain gene on chromosome 14 in the majority of cases, but occasionally to the light chain, immunoglobulin light chain loci on chromosome 2 or 22. And c-MYC, of course, is a very powerful oncogene. So this is the translocation in Burkitt lymphoma, where c-MYC is translocated onto the IgH promoter. And this causes constitutive activation of the c-MYC gene and protein. And MYC has pleiotropic effects throughout the cell, really driving cell growth and proliferation, protein synthesis, energy generation. But as we'll come on to later, it also leaves cells at risk of apoptosis. So it has an effect on both proliferation, but also tips the balance close to apoptosis at the same time. Here we have a description of what happens in the host cell in terms of pathogenesis with c-MYC that I've just referred to, and additional mutations that also enhance MYC-induced proliferation, such as TCF3 and ID3. EBV, where involved, does play a role. It's clearly not essential for Burkitt lymphoma pathogenesis, but where EBV is present, it contributes more to tumour survival rather than proliferation. So it limits or inhibits apoptosis through the BH3 protein system. These are population-based data, so this is what we see in real life. This is a fantastic population-based database collaboration through Leeds HMDS, the diagnostic service there, and York University, to give us a really good picture of what happens in a representative population in the United Kingdom. And you see here that these data are a few years old, but still valid to say that Burkitt lymphoma is rare. So when we look at across all blood cancers, it's down in the 1 or 2% range. And this is what Burkitt lymphoma looks like diagnostically. So we have our tissue biopsy, and you'll see on the right panel, just on the H&E staining, you can see these paler areas, which reflects this so-called starry sky appearance. And within these pale areas, you have macrophage activity consuming apoptotic cells. So you have spontaneous apoptosis and cell death within a very rapidly growing B cell tumor. So pan B cell markers are expressed with a dominantly germinal center phenotype. So there's no expression of post-germinal center markers. BCL2 protein is negative. If BCL2 protein is positive, that calls into question the diagnosis of Burkitt lymphoma. Very high proliferation rate by Ki67 towards 100%. So nearly all the cells are proliferating at any one time point, and the starry sky appearance I've described. And when we look using FISH probes, you can see that there's a c-MYC rearrangement with a breakaway probe strategy, and this is the isolated abnormality. So there's no other rearrangement of key genes such as BCL2 or BCL6. And this contributes to the diagnostic algorithm. I'm grateful to Kathy Burton from Leeds, just giving me this slide, just to show a very clear and logical way of delineating the different MYC rearranged high-grade B-cell lymphoma subtypes. So morphology is very important still, and as I just referred to, the phenotype needs to be consistent, and then you need to have a MYC rearrangement by FISH as the sole abnormality. If you have BCL2 and or BCL6 rearrangements, this falls into a different diagnostic category, the so-called high-grade B-cell lymphoma with those rearrangements. And if MYC's not rearranged, then that's much more in keeping with DLBCL in the pathological context. So there are a number of key considerations when we think about how we manage Burkitt lymphoma clinically. And some of these in themselves could comprise a separate talk, and I won't have the time today to go into details, for example, of the management of tumor lysis syndrome. But suffice to say that we, as clinicians, we need to recognize that this is a highly aggressive tumor, and we should consider it as a medical emergency in many cases. Patients are often very unwell at presentation. They commonly have gastrointestinal involvement, and this is characteristically in the ileocecal area. So obstruction and or perforation are not uncommon. Involvement of the bone marrow, often, and where this is the case, it's often effacement of the bone marrow causing bone marrow failure is moderately common, up to a third of patients. For all these reasons, patients have an impaired performance status, which can affect treatment delivery in the early days and weeks. Clearly, it's important to check HIV status. And really a crucial aspect of diagnosis and management is recognizing the risk of central nervous system involvement. Significant proportion of patients have usually leptomeningeal involvement at baseline, and without particular attention to the central nervous system during therapy, there's a very high risk of treatment failure within the CNS compartment. So we need to do early CSF analysis, including flow cytometry, and both intrathecal and systemic CNS-directed therapy should be built into protocols in most cases. And I mentioned tumor lysis. This can be spontaneous, so without therapy, just through the pathogenesis of Burkitt lymphoma that I referred to, but most notably in the early hours after initiating treatment. And this can be as simple as corticosteroids as an initial pre-phase, with tumor lysis monitoring within the first few hours really key. And we normally use rasburicase, the recombinant enzyme, to deal with the uric acid component of tumor lysis. But some patients need dialysis because of the calcium phosphate crystal and renal impairment. So what happens to patients with Burkitt lymphoma in a real world population-based settings? This is obviously not a trial. This is not trial data. This is just looking back again from the Yorkshire HMRN data set and comparing Burkitt lymphoma outcomes across different other types of different B-cell lymphomas. And you see here Burkitt lymphoma in the blue survival curve, approximately 2/3 of patients there having long-term survival. It's lower than we'd see in trials, as you'd expect from population data sets. But you'll see the shape of that Kaplan-Meier curve is an early fall off in terms of survival, so treatment failure and deaths are most common in the early months of therapy, and then very few events beyond a year or so. And I've personally never seen a Burkitt lymphoma case relapse beyond a year from diagnosis. So you can be pretty sure very early on following completion of treatment that a patient is cured, and the treatment failures which happened early are very difficult to manage indeed. More recently, from a large international retrospective study, we've learned on how to better delineate prognosis in Burkitt lymphoma using fairly simple parameters and not dissimilar to the IPI score that we use for diffuse large B-cell lymphoma. But this is a Burkitt-specific analysis generated in a big data set and then validated in a separate retrospective data set with 4 main risk factors: age over 40, different to the DLBCL 60 threshold, impaired performance status, perhaps not surprisingly, high LDH, serum LDH, and of course central nervous system involvement. So taking together these 4 factors, and you'll see on this first panel on the left the distribution of patients in terms of how many or what proportion of patients fall into each of those risk categories. And then on the right, how those risk factors translate into progression-free survival. So if you take the factors individually, you can separate those 5 different groups there, and then putting them together in a simple score of low, intermediate, or high, you can clearly describe different outcomes for patients who fall into the different risk groups, with the patients in the high risk group in the green there clearly representing an area that we need to do much better with therapy. So what do we use for treatment, or what are the optimal protocols for treating Burkitt lymphoma? The most important message I think to get across is that the principles of treatment is dose and time intensity of treatment, so delivering full dose of your chemotherapy schedule on time every time, using non-cross-resistant chemotherapy agents from different classes of drug, and importantly, including central nervous system therapy within your protocol. And that's usually, but not always, drugs that are given systemically and penetrate the central nervous system that way. Intrathecal therapy, as I mentioned before, is a key part of whichever protocol you use. So the CODOX-M IVAC regimen was actually pioneered a long time ago now in children by McGrath, and the drugs are listed there on the right that will be familiar to many of you and used across different lymphoma protocols. And this was further, this regimen without rituximab at that point was further studied in a British study, single-arm study more than a decade ago. And both studies, consistent with other trials, were able to delineate, not using the Burkitt lymphoma IPI, but using these other risk factors that I've annotated there on the slide, into low and high risk Burkitt lymphoma. But it's important to say that 80 or 90% of patients using this particular way of risk stratifying fell into the high risk group. So low risk Burkitt lymphoma is actually quite rare. The role of rituximab in Burkitt lymphoma wasn't addressed by those previous studies because of the time at which they were developed, but has subsequently been studied. And this was a big French trial, the randomized study, using quite a complex, intensive chemotherapy protocol that's not commonly used these days, but it was an important study because it was a randomized trial asking the question as to whether rituximab improves progression-free and overall survival in Burkitt lymphoma. And the short answer was yes, rituximab clearly makes a difference, perhaps not surprisingly, given the B-cell nature and CD20 expression, and now what we know about rituximab's role in other B-cell lymphomas, but an important study nonetheless to prove this in a randomized setting. More recently, there was a small UK cohort of Burkitt lymphoma within a larger phase 2 single-arm study of diffuse large B-cell lymphoma. And this is the Burkitt lymphoma cohort, which is quite small, and you'll see the numbers down on the bottom. but just to demonstrate that in this difficult group of patients, and these were patients who had impaired performance status, and some of them had CNS disease, reasonably good outcomes with the addition of rituximab to the Codox-M-IVAC schedule. And I just highlight the total numbers of patients were small, but this important aspect that you'll see here, that almost a third of patients, or perhaps just over a third of patients on central pathological review as part of the trial, actually had a revised diagnosis and were not thought to be Burkitt lymphoma. So this speaks to some of the difficulties in diagnosis and differentiating Burkitt lymphoma from the other MYC-rearranged high-grade B-cell lymphomas. So an important point to remember. More recently, there's been much interest in the role of infusional chemotherapy in Burkitt lymphoma, and this was a regimen, dose-adjusted EPOCH-R, that you may have heard of in other contexts. It was developed by the NIH in the United States, designed to preserve efficacy of dose intensity whilst reducing toxicity. So it's an infusional regimen with dose adjustments cycle by cycle according to the degree of hematological toxicity. An important point about this regimen is that the central nervous system prophylaxis comprised only intrathecal therapy, but there were no systemic active CNS agents that we would use in the Codox-M-IVAC protocol, such as high-dose methotrexate, ifosfamide, or high-dose cytarabine. So this was an interesting approach, which produced in this multi-center academic US center study some quite impressive outcomes. The caveat here, which I'll come on to in a slide or two, is the question about whether these patients who are in this trial are truly representative of the real world patients with Burkitt lymphoma that we encounter in routine practice. And there's likely to be a risk of selection bias because of the type of centers that recruited patients, and the performance status of the patients in the study was therefore better than we'd seen in practice. Nevertheless, some really impressive outcomes in terms of event-free survival and overall survival, with a large majority of patients, over 80%, being cured by this approach. So just a quick look at these different studies, just to highlight a few of the important aspects of comparing the patient characteristics within the different trials. This was the French study that I referred to. This is a very intensive protocol, and you'll see here approximately 10% of patients in the manuscript that died of causes other than Burkitt lymphoma and were effectively treatment-related deaths. So that's a very high percentage. Then we have the dose-adjusted EPOCH-R protocol I referred to on the previous slide, and you'll look at the ECOG performance distribution there. Most patients, 80% of patients, having an ECOG performance status of 0 or 1, and this is not, I think it's fair to say, this is not reflected what we encounter in practice. However, that study did include a good proportion, up to a quarter of patients who were HIV positive, which is important, and a relatively lower treatment-related mortality. And then the small cohort within the single-arm UK study, and you'll see here a much more difficult group of patients in terms of their performance status. Nearly half of patients had ECOG performance status of 2 or 3. This study also included the HIV positive patients, which is again an important aspect, showing that we can deliver either of these protocols in patients on highly active antiretroviral therapy. And again, a treatment-related mortality that we, of course, like to be close to 0, but certainly lower than the French study. So these data were obviously not, with the exception of the French study, were obviously not randomized. To date, there had been no randomized study of comparing 2 different chemotherapy regimens in Burkitt lymphoma. And these are very recent data published earlier this year in June at the EHA, the European Hematology Association meeting by the HOVON group. And this was planned to be a larger phase 3 study, but unfortunately the trial closed early because of difficulties with recruitment, and so we ended up with a smaller cohort of patients, but nevertheless randomized, more in keeping with a randomized phase 2 size study. So it didn't reach sufficient power statistically to draw the conclusions that that were intended. But nevertheless, it's fair to say, and looking at this overall survival data here from the oral abstract presentation, that treatment with the infusional less toxic dose-adjusted EPOCH-R regimen did appear to confer comparable response and survival outcomes compared with the more intensive inpatient delivered Codox-M-IVAC schedule. And not surprisingly, the latter intensive schedule was associated with more infectious complications, transfusions, and time in hospital. So an important consideration. We can't draw definitive conclusions because of the size of the study, but very good to see some randomized data in this rare lymphoma. Now, how do we then make a decision about between these different regimens for patients that we see with Burkitt lymphoma? I think it's worth then going back to the data I showed you earlier on the International Prognostic Index, the Burkitt lymphoma index, and considering what happens when patients in the different risk groups receive different treatments. Caution that this is retrospective data. This is clearly not randomized, but if you look at the two different treatment arms, the Codox-M-IVAC group on the left, and outcomes for patients treated with the DA EPOCH-R regimen on the right, and focus on the orange Kaplan-Meier curve. Again, not a randomized comparison, but useful to reflect back and look at these high-risk patients and see how they fared with the different approaches taken. And it would certainly appear that patients who had the infusional EPOCH regimen appearing to have less good outcomes than patients treated more intensively. So I think this should be a consideration when we're deciding what treatments to deliver. And we know that the Codox-M-IVAC regimen does confer more toxicity over the age of 50 in those patients with impaired performance status, and the treatment-related mortality there is higher. And so it may be that group of patients, the older patients or those with impaired performance status at diagnosis, for whom you may consider the dose-adjusted EPOCH-R regimen. CNS disease clearly better addressed by the Codox-M-IVAC regimen, and certainly that's what I would use if possible in those with CNS disease. So just to summarize, there's a lot to talk about in Burkitt lymphoma, in both diagnostic aspects, in terms of practical management, and then in terms of trial data to inform the best treatment regimen for a particular patient. It's really important to get the diagnosis right. Sometimes that's straightforward, sometimes it's not, but we really must use our multidisciplinary approach, assessing the clinical features, the morphology, which is still very important, the phenotype and the FISH, and specialist hematopathology reviews, really important, as we've seen from the revision of diagnosis within some of the trials. We need to have MIC rearrangement as an isolated abnormality in order to nail down the diagnosis. And it's possible that in the future we may see some additional utility of targeted sequencing or gene expression profiling. There is a mutational pattern in Burkitt lymphoma that's different to diffuse large B-cell lymphoma. Clinically, Burkitt lymphoma should be considered an emergency and really needs really close attention to all aspects of care, tumor lysis in particular, central nervous system assessment and prophylaxis. And they can be difficult patients to navigate through treatment, particularly in the early hours and days, recognizing that there's a very high chance of cure for those patients who are fit to be treated intensively. The principles of treatment: dose and time intensive, non-cross-resistant, CNS penetrating therapy, with encouraging data from the less toxic infusional regimens. The DA EPOCH-R regimen certainly promising and needs a careful discussion treatment planning for which patients are most suited to which of these potentially effective treatment approaches. And I'll finish there, and thank you for your attention.